European School of Oncology, e-session will start soon. Please hold on. European School of Oncology, E-session will start soon. Please hold on. Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to the e-session 521001. Today's session is COVID-19, Oncological Risks and Guidelines. As a reminder, during the live session, all participants can ask questions live at any time by simply pressing on the relevant button at the top of the page. Questions will be received by Dr. Marco Ciano, of the HRC Hôpital Riviera Chablais, Rennes, Switzerland, who will discuss them with Dr. Stefano Caffarotti, of the Bellinzona and Valley Regional Hospital, Bellinzona, Switzerland, and Dr. Angelo Del Monte, of the Romanga Scientific Institute for the Study and Cure of Cancer, Modena, Italy. Here is an extract of the policy which is published on our website in full. I will now hand over to Dr. Ciano. Doctor, your line is now open.
Thank you and welcome everybody to this session that we will have again on COVID-19, and the title is Oncological Risks and Guidelines. I'm very pleased to have two experts, one of them already having had a session some weeks ago, Stefano Caffarotti from Bellinzona Ticino, and the other expert, Angelo Del Monte from Romagna in Italy, very close to Lombardia, but I can say both of regions were very hot for COVID. Stefano, being a thoracic surgeon, will have a focus more on thoracic oncology patients. Also, Angelo, as expert in this field, but also in the phase 1 unit of the Romagna Institute, will give a talk a little bit in this direction, but show us perhaps also how the guidelines can be applied in a center who has a little bit prepared on this really huge wave that hit Italy. And that will be, I think, very interesting for everybody. So thank you for being here. And Stefano, I give you the word to start.
First of all, for this second invitation in the e-ESO community. So as you know, we are actually in Ticino into the store, and during the current COVID-19 pandemic, hospital leadership and healthcare providers are increasingly facing difficult decisions about how to conserve critical resources, such as hospital and intensive care unit beds, respirators, transfusion capacity, as well as protective gear. At the beginning of pandemia, the guidelines were established in Ticino by hospital leader and government to reallocate hospital capacity and to respond to the pandemic. And we, as a clinicians, embrace the authority requirement, and also focalize our attention on oncological patient needs. As all of you know, Switzerland and principally the southern part had to manage the storm with 10 days of delay compared to the North Italy. And thanks to this short delay, we had the time to prepare ourselves from both sides. I mean, hospital leader side and clinician side. Just 20 days ago, we had spoken together in a previous e-ESO session about the impact of coronavirus on oncological care. And we had also tried to answer to those specific questions that potentially could change the oncological management of our patients. As a clinicians, we tried to answer to this question also thanks to the available literature that at that time was just 2 publications coming from China. And what we conclude is that with the common sense and this level of evidence, we have to manage and deal with 2 risks at that time: the risk of cancer progression and the risk of infection. We also conclude that was strongly required general and specific guideline concerning the management of our oncological patients. Sorry, I don't know what happened.
Oops, we need some help here. Yeah.
No. Now it's okay.
Okay.
And now we are here today to discuss exactly this specific topic. Our publication on Cancer World magazine will give you all general recommendation. And today I'm going to speak about the specific guideline for lung cancer patients in our institution. For sure, we have also in the Istituto Oncological della Svizzera Italiana some general recommendation, and we have also specific recommendation for lung cancer center. So I focalize to this specific recommendation that will be soon published on Journal of Thoracic Oncology, and that focalize the attention on 3 different levels. The first level is the guideline that concern the surgical indication. The second one, the intensive care unit admission, and the third one are guidelines that are in the specific topic of reduction of in-hospital COVID-19 infection. So as you can see here, this is the guideline for surgical indication, and we establish in our lung cancer unit a new risk stratification for lung cancer progression and COVID infection, as you can see in the upper part of the table. We match both and elaborated a new integrated stratification risk in order to prevent adverse outcome of thoracic surgery patient. We promote new therapeutic options that, as you can see, are based on the integrated classification as follows. For the stage 1 or scenario 1, we promote surgery, like the same, it's exactly the same for the stage 2A. Both are patients with the low risk of COVID-19 infection. For those patients with a high risk of COVID-19 infection, that means elderly with more than 2 associated disease or with concomitant immunosuppression, we promote or personalized medicine or other treatment. This algorithm of care try to balance the risk of dying from cancer with the risk of incurring in a potential fatal infection after major surgical treatment. It's for sure partial evidence-based and mostly based on common sense and on the need of supporting our patient during current emergency. The second part of our guideline regards the equal admission plan. Now, I don't want to go deep into the discussion of this flow chart, but just to give you a spot information, we have select patient according to the European criteria risk assessment. So we assigned a score, and this score could give us a predictable rate of complication and also a rate of possibility to be admitted or not in intensive care unit. So thanks to this flowchart in the actual pandemic situation, we admitted just 2% of patients after thoracic surgery in intensive care unit, and in the pre-COVID time, we had a rate of 97%. The last part of the guideline regarded the goal to maintain the Department of Thoracic Surgery as much as possible like COVID-free. So as you can see, for all patients admitted in thoracic surgery, we establish some rule. First of all, we perform for any elective admission the test, COVID test, that must be negative before the day before, and so patient could be admitted into the hospital for elective surgery. And for emergency department and for other hospitals, so transfer for patient from other hospitals, we perform tests for COVID. The patient will be moved in another place in waiting of the test result, and just if it's negative, he can go. He can be transferred into thoracic surgery department. So what I can say that is thanks to our protocol, we were able to treat lung cancer patients with only one case of coronavirus test positive, and was not elderly according to our surgical indication, and this patient had no comorbidity, and thanks to this, patient could be discharged without consequence, no admission in intensive care, no IRDS, and actually is asymptomatic at home. I think it's very good news if we take a look at the American College of Surgeons guideline that suggests to defer all thoracic surgery procedure. So thank you very much for your attention.
Thank you, Stefano. I wanna say that the audience, they have the possibility to ask questions anytime. From my side, I have a little question before we move to Angelo's presentation. I know you're a surgeon. I anyway ask the question. Perhaps Angelo can say his opinion too. So you have this risk score, the risk of progression you define on TNM stage. And my question is whether it is not suitable also to include the biology of the tumor. So if there is a highly proliferative, low differentiated Ki67, MEB1 who's very high, so very active tumor, if this shouldn't be considered because perhaps a low grade, something really with a low proliferation, also the progression from a T3 is perhaps also negligible. I don't know what you mean about that, or Angelo, what do you think about that?
So I can try to answer my point of view, my surgical point of view. We did not perform a stratification of risk of progression according to the biological behavior or different type of lung cancer. We are speaking about, for sure, non-small cell lung cancer. And you know that early stage, I mean stage 1, on respect of stage 2, we have a reduction in survival that could be really important. And when we are in front of the tsunami of coronavirus, we want to preserve the possibility to perform procedure like the only step for this subset of patients. I speak stage 1, with low risk of infection, and give to this subset of population the possibility to not go into the hospital again for other treatment. So we use the TNM classification exactly for this reason in a surgical point of view, focalize our attention on the surgical non-small cell lung cancer, early stage according to the TNM classification.
Thanks. Well, there are no questions from the audience. Perhaps, Angelo, you can take over.
Thank you, Marco. Thank you for the invitation. This is a very big pleasure to be here tonight with you, this evening with you. And in the next 20 minutes, I will present to you how we have applied to our reality guidelines, or the very good guidelines born from the good sense, good common sense, and practical guidelines related against the pandemic events. And our reality is called Istituto Scientifico Romagnolo per lo studio e la cura dei tumori, more simply named IRST. IRST is a cancer center for the care and research in oncology and hematology, and it encompasses an hub and 4 spokes operating together and with the general hospitals in our area, which is called Romagna. As you can see in the picture, Romagna is located at east of Bologna in a region called Emilia-Romagna in the north of Italy. IRST is placed in the district of Forlì that you can see indicated by the star. Here, in this picture, there are resumed all the data concerning the pandemic in Italy. And we can say that in Emilia-Romagna is the second Italian region for number of patients positive for coronavirus. And you can see that from west to south, incidence is high in quite all areas with small differences among the areas. In our region, in our indication promulgated by Italian government has been applied in a very rigid manner, and each hospital is applying the regional indication in a specific way. At IRST, we have modified our activity and our organization with the main goal of keeping IRST COVID-free in order to permit to our patient to receive appropriate treatment in a safe behavior. Considering that in our area, at present, general hospitals are mainly involved in management of pandemic, with possible reduction of other activities such as oncology, IRST is able, by this way, to offer the possibility to continue their treatments for all Romagna patients. Our organization has been defined in order to reply to 3 major questions. Who has to be admitted, how to protect patient and staff, and if there's a place for or space for clinical research in this moment. In order to take care of instances of all the IRST units, our health management has established a crisis management unit in which clinical, radiologic, and nuclear departments are involved together with nurses head. We meet daily, facing organizational aspects and discussing clinical cases. Patients admitted to IRST are those who have to be treated both in curative and palliative settings, or those who need a radiological evaluation in order to define future therapeutic approaches. The major criteria for admission is to be triage negative. For this reason, we perform 2 types of triage. The first one, the phone triage, that is performed the day before the planned appointment at IRST. And the second, the day is performed the day of entrance in IRST. By phone, our professionals requires clinical information and with specific attention to symptoms. You can see in the picture the major symptoms resumed in a recent document by the Istituto Superiore di Sanità in Italy, and by collecting data concerning epidemiology and data about exposition to infected people of our patients who have to come here in IRST. The professionals who are performing the phone triage are acting according to a specific flowchart that I have shown here in the picture. I apologize, but it's in Italian because it's our workflow, daily workflow. And they give to patient a specific indication in order to have an admittance have been admitted in e-ESO or have the necessity to go in the general hospital. At the entrance of e-ESO, a tent of the Italian Protezione Civile is present, and inside the tent, nurses and volunteers perform a second triage in the morning, in which the patient is coming in to e-ESO, and they ask to patient their clinical status, how they are, and they take parameters not only of patients but also companions and all the health professionals who have to come to work inside the e-ESO. At entrance, a list of all the patients that have to come inside that day is present. Those who have a negative triage enter into the hospital to the main entrance. You can see here the route 1, who is the one for the healthy people. Those who are clearly infected go outside the black route, go outside the area of the hospital, and they go to the general hospital in order to be evaluated by infectious disease department. Finally, the orange route, patients who are suspected to be infected come inside the e-ESO by a different way from healthy people, and they come to a specific visit room in which their oncologist visit them and decide if they have to be undergo further exams. If they are suspected to be infected, they receive a nasopharyngeal swab and a CT scan of the thorax. If the CT scan of the thorax, which is the fastest exam, they will be sent to the infectious disease department. Workers not exposed to patient have a separated entrance, the blue one, in the back of the hospital. In case of symptoms, they have to stay at home and contact their own general practitioner, who will activate the diagnostic route for general population. Finally, for patients who have to be hospitalized, we have defined a complex decisional algorithm that you can see in the left part of the slide. At the end, all patients before the hospitalization have to undergo the swab the day before. If they are positive, they come inside, otherwise not, as it happens in surgery in Bellinzona. In case that the symptoms appear during the hospitalization, patient will undergo both to the swab and to the thorax CT scan. If there are any questions, Marco?
So far, there is one question. I think it's a question. Due to tumor heterogeneity and small size of lung diagnostic samples, maybe the clinical characteristics of TNM will be more easier to use or not. I think this is a follow-up question on that what I had. So it's easier also to respect the TNM. I think this is a question for Stefano. Otherwise, there are no other questions. So I think we discussed this with the TNM being for non-small cell lung cancer and more easy to use and to do the triage, basically. Angelo, I have a little question for you too, because you mentioned research and whether research is appropriate to do research in a situation like that. So it's clear if you don't have resources and if there is an emergency for the patients, for other patients, COVID patients, but is it justified to continue to do oncological clinical research like phase 3, phase 2 studies ongoing, or you put them on hold?
I will cover this topic at the end of my presentation.
Then I was too fast and we just continue with your talk.
Thank you. this slide, I have summarized the numbers of our activity in the last 20 days. As you can see, only 9% of our patients were positive to the phone triage, and only 28 patients resulted positive to the swab. This is a very important activity, and we have, as you can see, we are using a lot of energies from a personal point of view, professional's point of view, for facing these events. Patients with a simple follow-up have been delayed, and those with exams already performed received a telematic visit. To take care of our patient accountability in order to reschedule all the exams delayed, it has been created an informatic tool in which all the decisions taken for each patient, according both to phone triage and to status of oncological illness, are saved and considered for further planning of all the exam. In order to protect all the e-ESO population, of course, we have decreased the number of persons entering at e-ESO, with a reduction of daily accesses of approximately 35%. We have limited the number of relatives. We have delayed, as I said previously, deferrable follow-ups and limited monitoring visits for clinical trials and educational meetings. To everyone who is coming to e-ESO, both patients and healthcare professionals, surgical masks are furnished at the entrance. In case of diagnosis of COVID infection inside the institution, all the professionals use strongest DPIs, as you can see in the picture. And finally, before and after the use of each workstation, we used to clean the workstation with an antimicrobial sanitizer for surfaces. So we do also the cleaning work. Clinical trials, as you asked Marco, as you can see, we have had a reduction of 21% of our activity in this term. 21% of our trial has been put on hold by its sponsor that performed this action not only in our center but worldwide. And this is due to the fact that the sponsors are afraid that the infection can affect the protocol and producing deviations, and the fact that the reduction of the entrances in each hospital may affect the monitoring visiting with avoiding the possibility to have a strict control of the trial. Otherwise, as you can see, however, 80% of our trials are still ongoing, and we are at present offering this treatment to our patients. At the end, these are treatment as the others, especially when we consider phase 2 and phase 3, and they can be managed being very taking attention in a very strict way to protocols rules. And from my point of view, this situation is not a situation that can limit our recruiting, our recruitment in our institution. Finally, we are trying to perform research also in the coronavirus field, looking if there are if there can be connection between the virus and oncology field. And we have created this course trial, which is an observational trial in which we will perform two things mainly. The first one, we will evaluate the serum prevalence of IgG and IgM against the coronavirus in asymptomatic oncologic patient, and in healthcare professionals. Second point, we will test two types of swabs, the nasopharyngeal swab, the classic one, and the serological rapid test in order to evaluate IgG and IgM for fast diagnosis of the infection. Third point, we will evaluate the characteristic of virus according to our Italian macro-region by evaluating the different RNA sequences of the viruses in patients that will be positive for the infection. We will plan to recruit 352 healthcare professionals and 50 oncologic patients that will arrive at e-ESO in order to receive the myelosuppressive treatment, chemotherapy at the end. And they will receive nasopharyngeal swab at time 0, after 3 and 6 months. Probably we will update another picking point after the 0 time, after 1 or 2 weeks. And rapid test they will receive also rapid test for serological IgG, IgM presentation. And finally, they will undergo to a phone follow-up every month. Conclusion, I hope to has been clear in my presentation. This event is requested a dramatic change in our organization. Patient and healthcare professionals, fortunately, have responded carefully to those changes, accepting that the rules that we have placed are useful for their healthcare, and close cooperation among professional and health managements of the hospital has created a strong protection for its population, permitting to continue to take care of our patients. Thank you.
Thank you, Angelo. This was very interesting, and compliments for your course of trial, because one problem with this coronavirus and this huge wave coming in is that we don't have data. We don't have data on treatment or efficacy, and so this is also a problem. Also, to even know which patients are infected, and if every patient infected in oncology, what are the consequences? Probably there are a lot already infected, but there are not many or not important consequences. One question that arises during your presentation, also with the research part. So I think anyway, the normal activity of Unity is going lost. So we don't have money coming in, no, for the hospital. Also, your unit for the surgery you don't perform in this moment. So this is also a political and financial question. So who's going to pay for all that? So in Switzerland, we are even in a rich country, but there is also the problem at some point, all these losses have to be balanced. I don't know what's your opinion on that, but is it the patients at the end, or is it the taxpayers? What do you think?
Fortunately, I can say in Italy we have a completely different system from yours, because healthcare system is public, and at the end, yes, of course, we will pay it with taxes, but fortunately, we will have the possibility to face this emergence. There are different type of way to react to this situation. The way I show you is one in Emilia, one in the Emilia-Romagna region. In Lombardia, there are other type of way to react, depending on the ability of each regional healthcare system to face this situation. Fortunately, in our area, in my area, the Forlì district, we have had enough time to study what was happening in other parts of Italy and prepare in a more careful way, probably, because we have seen how the other react to this situation. At e-ESO, we have had time, enough to prepare, who will pay? Certainly, everyone will pay in all the society, not only from the healthcare point of view, but also from the society point of view. And from this situation, fortunately, a public healthcare system will cover many situations that in other situations won't be faced.
Nice stuff. Thank you, Angelo. There is a question from the audience, and I think it's directed to Stefano, and he's mentioned publication. So please, the question is, where will be this guide on lung cancer patients during COVID-19 be available? Probably the question is, where will it be published, or is it published soon?
Published on Journal of Thoracic Oncology very soon. Reason of why I cannot be much more precise in my presentation because it's not still on the paper, in preview, so it's not possible for me. I at the beginning hoped that I could be much more precise in my guideline. At the end, I give you just a preview of the publication that will appear on Journal of Thoracic Oncology, I hope next week.
So JTO, and we will stay tuned. I have another questions because when I saw your presentation, I got a little bit anxious because I thought, okay, this is very well done and thought of for lung cancer or thoracic cancers, but probably we should do it for any other entities too. So gastrointestinal cancers, it's the same thing, like esophageal cancer. Also there probably we know a TNM classification, risk stratification. And at least in my department here, we didn't do the job yet. So we are not in this emergency as we know it from Italy, but probably it will be good to have it also for other tumor entities. What do you think, Angelo?
I think that Stefano said a very important thing. Guidelines in this situation are very important, but good common sense and our clinical practice is very relevant in this situation. We cannot, I think that in our field there are situations that are rapidly progressing and very frequently it's difficult to identify them just from the baseline characteristics. Very frequently how they go, how they move is the most important. So I think that we have to improve for each specialty our multipathological teams and faced case by case with them, because by this way we can avoid to generalize and we can face case by case.
Thank you. Then I have another question. There are no other questions from the audience. From my side to both of you, because now in some areas we see a decline of the cases, or there is the impression, perhaps it's too early because everybody has feared that there will be another wave and things like that. But anyway, perhaps it goes in a good direction. And then the question is there when we can release these efforts or when we can go back to normality. And then the question is, what do you require in your department to return to normality? What do you want to see? A steep fall of the cases, no COVID positive patients coming in the department? What are the requirements for you to start to lift up these measures?
So I think for thoracic surgery and lung cancer center, we have to consider that we have the target organ of this coronavirus. And so I think we cannot go back at the normality in soon. We need to have full capacity of intensive care unit. So when the government restart to release population to the normal activity, we have to take a look about the pandemic curve. And when all situation in the epidemiological sense go back to the normality, I think when we will have some specific drugs is the answer. For that for the moment, I think we cannot go back to the normality. We have to wait the epidemiological situation, and we have to wait specific drug that could fight against the coronavirus.
Thank you. Angelo, your opinion?
Everyone in Italy is saying everything will be okay. For sure, everything will be okay, but I don't know in how many time. And from this point of view, my impression is that it will be a very long situation in which we will expect certainly drugs such as vaccines, and we hope to have it in a very fast way. But my impression is that for a long time we will have to face with this situation, and we will have to decide how to treat, when to treat, searching the virus before acting. I mean, in the sense that swab and CT scan that we have to perform as baseline condition, they will be helpful for us. And be carefully from a clinical point of view. We can do our work despite the virus.
Thank you. I agree with both of your opinions. There is a question from the audience. So regarding the metastatic cases, when should we do the evaluation during the treatment? Can we depend on tumor markers evaluated and clinical improvement? Or when would you do the restaging? I think we are talking about the restaging, the CT scans. If you can avoid to do examinations, probably you can evaluate also clinically the response. So you avoid them, Angelo, or do you just stick on your plan as you did before in metastatic patients?
I think that we can divide the two situations or three situations. The first one is people who are receiving chemotherapy. I think that in this setting, chemotherapy has to be performed as usual without changes. Because, chemotherapy as an end. And after 6 courses, I'm talking about lung cancer and so on. And for this reason, I think that we have to carefully monitor our patient, continuing as we did, because toxicity from chemotherapy can be stronger than in other situations. The second situation is, I think, the use of TKIs. Patients who are stable during TKIs can be deferred from a point of view of the evaluation. I mean, if we are coming from the past with a patient with 2 or 3 evaluations in which we have seen clinical responses and stabilization, and from a clinical point of view we don't have any news, we can delay for 40 days our evaluation, I think, hoping that this pandemic will passes at the end, or will be limited. And the third point is patients who are receiving immunotherapy. This situation is that will be similar to TKIs, but it's not. It can be similar to TKIs from this point of view, from the point of view of the lung toxicity. We have had several problems to give the right meaning to interstitial disease in patients receiving immunotherapy in this period. And we have to be careful. For this reason, I will suggest to continue the follow-up as we performed before. But in case of patient with a long period of stabilization, we can delay. Patient with symptoms, we have to be careful and cooperate with pneumologists, performing endoscopy for bronchoalveolar lavage more frequently than we did it before.
Thank you. And I profit to place my last question. Angelo, it's to you mostly because we discussed it also with Stefano the last time. So I'm very hesitant to continue the immunotherapies in these patients who have a COVID infection or who are suspected to have a COVID infection because of the fear of the cytokine storm. And so what do you think? You hold immunotherapy, and do you think this could accelerate a cytokine storm or an immunologic state with this overreaction at the end killing the patients? Or do you just continue the immunotherapies?
As my colleagues said in our meetings, at the end in oncology, when we have an infection, we avoid to treat generally. For this reason, if we have an active infection, I will be afraid to continue to treat patients, even also with chemotherapy and with TKIs or immunotherapy. For this reason, I rather prefer that the infection will be resolved, and after I will start again.
Thank you, Angelo, and thank you, Stefano. So there are a question coming in at the last second. Are the staff on screening against COVID-19 or only symptomatic staff have swab tests? Yeah, I know this is quite differently handled in every centers. How do you do it in your place? So for us, our staff is not systematically screened, but only if they are symptomatic, they get a swab. And in your centers?
Also in our site.
In our site, in my site, I tested all the staff, all the personnel who have been in contact with infected people, of course. Mm-hmm. And all of us are entering the course of trial, so all of us will be tested.
Okay, that's good. So you have to test anyway. Thank you to both. We are at the end of the session. I think it was, again, very interesting. And in a field where there is a lot going on and a lot is said, to have really some practical recommendations and this worthful discussion. Thanks to you both. And yes, so I close the session, and I'm looking forward to meeting you in person at one of the next congresses that we can attend after the Corona storm.
Okay.
Bye-bye.
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 Thank you, Dr. Caffarotti, Dr. Del Monte and Dr. Ciano. Ladies and gentlemen, the session has now concluded. The next e-ESO session will take place on the 9th at the same time, and Paolo Casali, of the National Cancer Institute, Erx Foundation, Milan, Italy, will discuss with Professor Jean-Yves Blay, of the Université Claude Bernard Lyon and Saint-Léon Berd, Lyon, France, the following topic: the rare cancer oncology. Thank you for participating, and have a pleasant evening, day.